1 o'clock. We're going to go ahead and convene today's Division 3 Finance. Today is Monday, February 10th. Today we will hear presentations from the department on public health, developmental services, and elderly and adult services. And then if we have time at the end or interest, we might allow public comment. Who wants to start from the department? All right. So let me tee this up. So this has been a difficult request that I've made of the department because we're we're so close to having the governor's budget released. There was some question of why I wanted us to meet, and so what I've done is you're the assistant commissioner or the director? Or?
Associate Commissioner.
Associate Commissioner. Okay. Congratulations again. So I had a chance to talk to the Associate Commissioner about it, and I reiterated our promise that the committee won't be asking about dollars or numbers of FTEs or any kind of manpower. But I did ask her to focus on kind of an audit trail almost. It's not exactly that, but sort of a history of the programs that are in public health now and how they got there. And so, and then we're also going to talk about some contracts with UNH, right? So with that, you're welcome to begin.
Thank you. Thank you so much. So for the record, my name is Patricia Tilley. I'm an associate commissioner here at the Department of Health and Human Services. Thank you for the opportunity to come and talk to you a little bit about public health. I want to give you 5 things over the next 60 minutes or however long this takes that I hope that will inform your decision making as you wrestle through the budget. I know that you have a lot of work ahead of you. And so these 5 things are informed by history, by data, and by the needs of your neighbors, your friends, and the people that you represent. So here's the 5 things that we're going to talk about. As requested from Representative Edwards, I'm going to walk through the history and the authority of public health that led us up to our current organizational structure, pre-pandemic and post-pandemic. I'm going to highlight where the general court has historically invested some general funds in public health. No numbers, but I'm going to just sort of tell you where they are. I'm going to describe how the division has reorganized over that pandemic into its current configuration. And then 4, I am going to transition, if time allows, into addressing some of the questions that we had the last time I was here when I talked about behavioral health and DCYF, to talk about the role of prevention, public health, and that continuum of DHHS services. And then 5, of course, is to answer any of the questions that you have as we go forward. So that's my goal as we go through here. So if we jump in, that second slide, you'll notice that this is the 3rd time you've seen slide 2, and you're going to probably see it maybe even one more time today. And my conversation today is really going to focus on the base of this figure that supports the building of the foundation of optimal health and well-being for everyone. As we transition into just the little bit of the history side of today, you're going to have to indulge me in a few minutes as we talk a little bit about where we got here. And I'm going to start you back in 1882. Actually 1881. It's hard to believe there was a time when there was not a Department of Health and Human Services in the state of New Hampshire. It was actually legislated, put into being in 1881. The first department was in place in 1882. And I just want to have you think about that moment in time. And I actually have the props sitting behind me. I actually have the initial very first report from the Department of Health from 1882. It used to sit in my office when I was the director of public health. So back at that time, and I think you're going to find some parallels, municipalities and individuals were navigating industrialization in the state with new opportunities for work, new opportunities for wealth, but some of that came at a cost. At that time, smallpox was running rampant in the mills. And it was popping up all over the state, and infants and children and pregnant women were dying from complications of birth as well as infectious diseases. Our industries, agriculture, and human waste was actually contaminating the rivers in the state and our water supplies, and our food and milk was rampant with adulteration, with contaminants in our food and milk. And so that's where the state legislature said we need to do something about that. So on slide 5, you'll see the opening paragraph from the first report of the Department of Health, and this, which is now RSA 125.9. So you'll see that opening statement. It is now translated into this foundational piece of authorization, which is that now the Commissioner of the Department of Health and Human Services shall take cognizance of the interests of the health and life among the people and make investigations and inquiries. And so that is what we do today. You know, you can speed through and look through at your time on your own leisure around slide 6.
Could you give me a moment? Because
Yeah.
I think I'm on the wrong, okay.
Oh, sorry.
No, that's me.
Sure. So by the time you get to slide 6, this also takes you a little bit through the history where 1901, we set up a public health laboratory, which we still have today. There was legislation in 1909 that allowed us to have inspectors of sorts, food and otherwise. 1921, we started talking about maternal and child health. And in 1986, we specifically carved out communicable disease. All of that provides a background of where we are today to get to Representative Edwards' question on slide 7, which is, what did public health look like before the pandemic? So on slide 7, you'll see our state fiscal year 2018 Division of Public Health Services org chart. You'll see 6 bureaus. I will give you that we had 250 full-time authorized positions for the state fiscal year 2018 budget. We then move into slides 8 and 9, and that describes the programs, how they existed for the 2018-2019 budget. As a reminder, you know, most of
Question.
Correct.
On the slide here, do
Yes.
these names map into the activity descriptions?
Yes.
In the budget? They map 1-to-1, or are they close?
They are 90% mapping there, and as you move into slides, and again, this is from 2018. So as you move into slides 8 and 9, they should match.
Thank you.
Okay. So as you move into slides 8 and 9, this is just at a very high level what those bureaus mean, what the main programs in each of those bureaus. I've also highlighted where historically there have been general fund investments. There are general fund investments for maternal and child health, mainly as a match to something called our Title V grant, which is the federal funding. Another fun history fact, it's the oldest grant to states was maternal and child health, federal grant. So MCH has been around since the 1930s and morphed into a block grant as we know it today under the Reagan administration. So long time work. When it morphed into a block grant, at that time it was required to have a state general fund match. We have a limited amount of general funds around child vaccine in our Bureau of Infectious Disease.
I'm sorry. I just want to make sure I understand I'm listening right. General fund match, does that mean this is a 50-50 program, or you don't mean to be that precise?
I don't mean to be that precise. For this particular grant, it's you have to maintain, it's more of a maintenance of effort. So you maintain the amount that was there when the grant initially went in. So
Okay.
there's a requirement to have a maintenance of effort,
All right.
to be more precise. Thank you for that question.
All right.
There's a little bit of money in for infectious disease, for childhood vaccine, money in our public health laboratory. That's where the greatest bolus of general funds is to maintain that laboratory that started in 1901 and is extraordinarily important to this day. And then as we move into slide 8, in food protection, and then back in 2018, general funds and our state loan repayment program. So again, highlight that this is where strategic investments have been made over time and what the division looked like pre-pandemic.
You're doing great. I keep tripping you up, but the state loan repayment, there's deeper slides on this. You'll be more specific about who the intended beneficiaries of those repayment
I
programs
have,
are.
I don't have specific slides on the state loan repayment. I'm happy to take questions and answer them.
Okay, so let's just hang a comment off of there. It would be good to see sort of an itemization of what kind of eligibility there is for state loan repayment.
Sure, I can tell you that off the top of my head, and then we can follow up with additional information if you would like. So the state loan repayment was designed to be a state program that provides educational loan repayment for healthcare providers. When it was designed originally many years ago, it was really focused on physicians and to get them to rural areas. To qualify for the program, you must agree to work in an underserved area. Oftentimes, that's our federally qualified health centers, rural areas, or where there's a population where there's unmet medical need. I can't remember the name off the top of my head, but underserved areas. The state, you then sign a contract with the state, and we give you 3 years worth of loan repayment, assuming that you stay working for those underserved populations, either in a federally qualified health center or a hospital. We expanded this program several years ago before the pandemic to include behavioral health providers. And so, quite frankly, the majority of our state loan repayment right now are for behavioral health providers down to the master's level. Anyone who is certified to bill, essentially, may have access to the state loan repayment program, again, that they serve underserved areas. So folks like our community mental health centers are big users of the state loan repayment for their staff. Is there anything else you'd like just off the top of my head?
Representative Wallner?
Just I wondered if quickly you could tell us maybe how many providers have been involved in this loan repayment program.
Thanks for the
still-
question. I can't tell you the number off the top of my head. This program has expanded and contracted over times. We used some ARPA money during the pandemic, so we were able to open up the doors even wider, and not only attract additional folks, but actually continue beyond the 3 years for some. We were able to extend with some of those ARPA funds as well. We can get back to you with the exact number. But I can tell you that the proportion right now is really in the behavioral health world. We still have some dentists who we brought on dental providers and dental hygienists to match up with the Medicaid adult benefit so that we could make sure that if they were serving a Medicaid population, they would be eligible for state loan repayment.
Thank you.
This is good. I'm learning more every time I hear this. And so the definition of an underserved area where the medical need needs to be provided, it would be interesting to later to hear how that analysis is done.
Great. There is a pretty standard analysis that we use across the country. It's what's used to designate our federally qualified health centers and rural health centers. So it's a little bit complicated. I can't rattle it off the top of my head, but there is an analysis that we use from the federal government to determine medically underserved areas.
Representative Nalvanko?
Yes, Mr. Chairman. You said that predominantly the shift is a follow-up to Representative Wallner's question, that the split on who is the growth in this has been predominantly in the behavioral health providers.
Yes.
Roughly ballpark so the split, as you see it, 80-20, 50-50.
It's actually probably close to 80-20 right now. And mainly because we've expanded to the types of providers so that we have master's level clinicians, as opposed to when SLRP was sort of first imagined, which was really thinking about physicians. The good news about getting down to that master's level group is that we can serve more people. The dollar amount that we give for loan repayment is built into our system, so we give more money to physicians and dentists who have higher medical or dental school bills than someone who is at a master's level who has who has some loan repayment, but it's at a lesser level. And so we proportionately give a smaller amount to folks at that master's level versus the MD or DMD level.
So one quick follow-up. So, not to get into specific numbers, but so the split on the total number of providers, roughly 80-20. If you looked at the financial split, would that, and given the explanation you just gave, would that significantly alter that?
So so what I will say is, just to reiterate, we're able to serve more people at the lower level of clinicians. I don't mean that, but it's sort of that mid-level of clinician. We can serve more people because we can make the money spread a little bit farther.
Okay, thank you.
Yep.
Representative Daniels.
Thank you. Looking at the 2018 structure, are any of those programs mandated by the federal government?
So that's a great question. I think many, roughly, especially in 2018, about 85% of the funds for the Division of Public Health were federal funds, or sometimes other funds. But, that's roughly been the split: 85 federal or other, and then 15% general funds. So by mandated, we have grants for each of those. So we do that work. I would have to get back to you of exactly if there were any federal requirement for any one of those programs, but I can tell you that they're mostly federally funded.
Okay. And just beyond on the other research, are there any mandates that have been placed upon us that are not funded?
Thank you. I don't believe there are at this time.
Representative Priest.
Thank you, Mr. Chairman, and thank you for taking my question. Can you speculate why there has been a raise in the number of behavior health needs in this state? Is this because of the post-pandemic and
Thank you, Representative Pierce. Priest. That's the $1 million question, isn't it, right now? And if we have time today, I have a few slides here really talking about the base of some of those behavioral health needs, especially as you think about the experiences that children go through, something called adverse childhood experiences. There's that component. There's also lots of components around issues of the concrete supports families need, the stressors that have been on them. That was certainly exacerbated by the pandemic. So I can get to that later.
To nail down Representative Daniels' question a little bit more, I hear you that we receive federal funds.
Correct.
And when we accept the federal funds, we're accepting the mandates that go with them.
Correct.
So I think the distinction that we need to have is those programs that were required by federal statute to have, and those that we basically opt into because we opted to take the grant. I'd like to be able to understand that demarc.
Nathan's going to talk a little bit more about that.
Sure. So, good afternoon, members of the committee. Nathan White, Chief Financial Officer of the Department of Health and Human Services. One really important thing that I just want to remind this committee about before we get too deep in the weeds today is that right now, we are preparing all of the House presentations. And many of you will probably remember, I think Representative Mooney referred to it as the coloring books that we bring. We'll be bringing those back again. And within those, we go through every bureau and every account in the programs. And we also have these documents called budget briefing books. And for each one of those accounts that are over $1 million, we include what are the outputs, what are the deliverables, what are the federal requirements, what are the different funding sources, is there a match, is there maintenance of effort? And so we'll be providing those books. This is part of the challenge between having these discussions before the governor's budget comes out. So I just kind of want to highlight that and have that in the back of all the members' mind that we will have that documentation for you here. And that's prepped and ready, but we just need the governor's budget to come out so we can start to get into those numbers and some of these specific questions.
Thank you. Thank you. So if you slide to slide 10, please. This is the org chart that Director Ian Watt is going to be presenting exactly during those budget hearings right now. This is the constellation of programs within the Division of Public Health Services as of today. And you'll see a couple things. We have reorganized some bureaus. We moved from 6 bureaus to 7, and that is because we've had the Emergency Services Unit, which is now called the Bureau of Emergency Preparedness, Response, and Resilience. But it's important to note that within this new structure, this new org chart, we still roughly have the same number of full-time authorized positions. Again, we're going to talk more about that when you have your budget presentation. But while this looks like a big shift, in reality, we are moving some of the pieces around to make more organizational sense, especially over the course of the pandemic. So if you look to slide 11, here's the things that have stayed the same. Our Bureau of Laboratory, our Bureau of Infectious Disease, Public Health Statistics and Informatics, and the Bureau of Public Health Protection. They are largely the same as they were in 2018. So good news, all of that. We have been doing that work for a long time. It has roughly stayed the same, even through the pandemic. As we exploded in temporary staff, those numbers have also come back down to pre-pandemic levels. So you saw this, but our full-time authorized has stayed flat during that entire time. So let's get into a little bit more detail of what moved where. So if on slide 12 you want to take a look at, the first thing that you'll note, pre-pandemic 2018, we had something called the Bureau of Population and Community Health. And in that bureau was our maternal and child health programs, our WIC programs, all of our chronic disease programs, and our tobacco programs. At that time in 2018, that bureau had more contracts in it than any other division in the Department of Health and Human Services. It was a large number of federal grants and a large number of community engagement and community partnerships. So for that reason, it made sense to split it in half. The span of control was too wide in that program, and we needed to have the expertise that could really manage and the leadership to manage those. So we split it in half into a Bureau of Family Health and Nutrition and a Bureau of Prevention and Wellness. Family Health and Nutrition is essentially what was maternal and child health and WIC. Prevention and wellness is all of our vast array of chronic disease prevention programs and tobacco. That's how those two things were split. You'll see in a minute that we've added a couple of other things into the Bureau of Prevention and Wellness. So that's a big change. So no net new, really. We were just sort of going from one to other, splitting it in half. The next thing, as I mentioned earlier, we had our Emergency Services Unit, which was located in our commissioner's office before the pandemic, mainly so that it could provide support for any emergency response across the department. The pandemic happened, and the Emergency Services Unit essentially was deployed in many ways to the Division of Public Health Services to help with that response. The Emergency Services Unit was responsible for putting on those big vaccine events, the events that were at the racetrack, our Blizzard Booster Blitz. All of that was done by our what was then the Emergency Services Unit. And because of the alignment between public health and their work, it made sense to just move it all within the organizational structure of public health to keep those lines of communication good and also the lines of responsibility also. So that part and parcel just moved over to DPHS. To this day, it makes a ton of sense. They help us on all sorts of responses from, you may recall, we had a measles outbreak in the Upper Valley this summer. We've had Legionella. Even this past week, you may have seen in the news that we've had a case of something called Mpox. They help us day to day and are very tightly connected with our infectious disease program. I'm sorry,
It says emergency, but do they also take standard missions like when the start of school shows up? Do they help coordinate vaccine programs for?
No, it's really about emergency events. They also have a responsibility to work with Homeland Security. So those of you who are familiar with the way Homeland Security works, there are these things called essential functions, ESFs. And so they manage housing and health and wellness. So they have a foot over, sort of a dotted line over to HSCM. So a different way that isn't necessarily seems directly related to public health. When we had the eclipse last spring, they were deployed to make sure that we had first aid available in all the areas in the North Country when we had that rush of tens of thousands of people. So those are the sorts of things they work on.
Thank you.
Yeah, Mr. Chairman,
Representative.
I have a quick question. So this is staffed for emergencies, but is it a flexible staffing situation? Or, I mean, if you don't have if you don't have a lot of
That's getting a
emergencies-
little close to where we're not talking money or
I'm not talking
manpower.
money, I'm just talking,
Manpower.
I can
We're not
answer
talking-
that. I can answer it quickly. It is a fixed staff, and then we have volunteers that flex as we need them.
okay.
Thank you. So, because we're always mindful, if you go to slide 13, of not expanding our footprint too much, so you'll know that we split that one big bureau, Population Health and Community Services, split that in half. We added ESU, and so we reduced something. We eliminated what was then a bureau of public health policy, systems, and performance. We eliminated that bureau and realigned those programs into existing bureaus. So we took the Office of Rural Health and Primary Care and the State Loan Repayment Program, put that in the Bureau of Prevention and Wellness. We took our therapeutic cannabis program, some quality improvement work, our legislative liaison, and put them directly under our deputy director at the Division of Public Health. So we just moved the deck chairs a little bit to balance span of control, to make sure that there was an equitable lift across all of our bureau chiefs. So then you will move into slide 14. So those were the bureaus. That's how that structure went from 6 to 7 bureaus, mainly because we added that emergency services unit. We split one bureau and then eliminated another. So that's how you got from 6 in 2018 to 7 currently. There's also important to note, as you do think about the funding, again, when we go through our budget presentation in a few weeks, we moved some programs as well. One of those was the prescription drug monitoring program that was in the Office of Professional Licensure and Certification. Around 2018, I could go back and find the date, the legislature moved that authority into public health. So they are now nestled in that Bureau of Prevention and Wellness as well. So PD&P came over. There are no general funds associated with that, but just for your knowledge, that's just moved in there. And then 2 areas where we do have general funds are 2 programs called Comprehensive Child Family Supports and Services, CFSS, you'll sometimes see that as, and Support for Our Family Resource Centers. These were funded in the Division for Economic Security. So at some point, even prior to 2018, they were funded out of DCYF. They now live in the Division of Public Health Services. So that money moved with them and traveled with the programs, general funds, into the Division of Public Health. It was budgeted in other areas of the department before then. So I'll pause there. Great. So that's all I have for just the organization. You'll see, again, when we talk about the budget, you'll see how there are some increases in general funds, but mainly that's because of some of these moving parts that just moved from one part of the department into this part of the department. Representative Edwards had some questions around UNH contracts, so I can talk about them right now.
Okay, I'm just looking to make sure I can map later the accounting activity descriptions with your slide deck.
Sure.
And so without looking too closely, like I see administration down there on 5131, 8579, those 2 towards the bottom. Are they written up in your slide deck here?
Are you look? I'm sorry. What are you?
Okay, so I got an insider's copy of an
Budget.
abstract of the accounting units for, did it get emailed to all of you?
No, at this point, I've only shared it with you and Representative Mooney because we were the only ones who talked about it this morning, but I have copies that I can hand out to the committee if you'd like.
Yeah, could you? Yeah, thank you. So I'm just going to want to be able to go down the lists and know which one is which on the activity descriptions.
Sure. So, it depends if we're referring to an activity or an accounting unit. Generally speaking, though, most of those should map. And when we do our presentations, we will have the bureau and accounting detail, and we'll be covering all of the various functions of each area. So there will be a tie back to
Okay.
that during those presentations. That'll be very clear.
Perfect. Thank you.
Thank you. So let's talk about UNH. You had some questions, Representative Edwards, around Division of Public Health's partnership with the university.
I did. I understand we have 4 contracts. They've been around for a while. They are planned to continue. I don't want to talk about dollar amounts.
Sure. So if you look at slide 15, I have 2 of those 4 contracts. The 2 that are not there, I'll start with that. One is a contract that has not moved forward, so we just took it off the list because it's not current right now. The second of the 2 that you don't see, we had a contract with the University of New Hampshire for a fellowship, essentially a graduate level intern over the summer. So I did not include that just because of the transient nature of that. It was just for that internship for a UNH fellowship for the summer. They worked on our food protection program. They were great, but it was very time limited and less than $10,000. The 2 main contracts that we have, though, and we are continuing, are our maternal and child health epidemiologist. So for almost 20 years now, we have been working with UNH to have a PhD level professor who is expert in data analysis and maternal and child health partner with the Division of Public Health to do the complex and sophisticated data analyses that are required in order to look at the health of moms, babies, and kids. This has been a really extraordinary partnership over the time. It allows us to get, again, PhD, high-level, sophisticated analysis access and in order so that we can do the sort of program planning and evaluation that we need to do to make sure that we're making good choices about where we put programs, what we invest in. And not only does this help the Division of Public Health Services, it's also been really helpful for Medicaid to have somebody who understands not only the data part of it, but also the programming and the content around maternal and child health. To get those 2, if someone with those 2 pieces of knowledge together, typically they are in an academic environment. So that's been a great contract. We look forward to continuing it.
So on that, I'm looking down at the bottom of that column, and it says to help the department make data-driven decisions to improve health outcomes for mothers and babies.
Yes.
So I understand the theory, but would you be able to give specific examples at the right time to show us the connection between all this great work being done in the academic area and how it's translated to changing patients' lives?
Sure, we're happy to do that in depth at some other time, but I can give you one example right now, postpartum coverage. The General Court was very generous in the past sessions to extend postpartum care for women on Medicaid to 12 months. The data analysis of that was done in part by this maternal and child health epidemiologist.
Okay, because in my life, I've seen really great reports that don't do anything because nobody takes the information and does something with it. And so I don't want to be building beautiful documentation that doesn't really matter to people.
I appreciate that. We use it to determine where we put our services. For prenatal care or to highlight, there was once a time where we did teen pregnancy prevention programs, and we used the data from this epidemiologist to pick the areas in the state where that would be most effective, not only where the teen birth rates were high, but where there were other contributing factors. We've done that for other programs as well. When we only have a limited set of dollars and we want to focus them on where they're going to impact, we use our MCH EPI.
Super, thank you.
Sure. And so the other piece the other contract that we have in public health right now is for the Pediatric Mental Health Care Access Program. These are federal dollars from CDC that help us connect providers to providers. And we're going to talk about it a little bit at the end of my presentation as well, but at a very short level, or a very high level, The University of New Hampshire does something called Project Echo, and that's where they do training for providers on a number of different topics. And so we have contracted with them to do training with pediatricians, primary care providers, to help them understand what they need to know from child psychiatry. Because as I talked about last time we were here, the pediatrician really is the front line when we're talking about behavioral health. And so it connects pediatricians with psychiatrists, and they do some cross-level training and also does some really interesting teleconsult visits. So, yes.
I didn't want to interrupt you. I just thought you were about done. Okay, so I can see the practical value of this, but as I see it, it feels to me like this should be more of a temporary transitional program because it's essentially doing what professionals do anyways. They have continuing medical education programs. They have societies that tell them what they need to know and what's the hot topic. They provide some resources. The teleconsultation is a new media relatively for them to be able to crosstalk with each other. And so I see this in its stable state to be kind of the natural order of things without a requirement for an explicit state-driven program. And that's my thought. So do you want to comment on that?
Sure. So it's a federally funded program from CDC. I don't know how long, and by that nature, it's temporary. We have a 5-year grant and we do the work, and then CDC decides what they want to fund moving forward, and we decide if it still makes sense for us. So it is time limited in that way. And so we have been using the past couple of years to stand up the program, build the cohorts of providers.
Yeah.
Someone's got to coordinate all that. But is this going to be in place 10, 15 years from now? I would suggest probably not. We will probably be doing something else by that time.
Is there a share with general funds in this? You
No,
mentioned federal
it's
funds.
all
This
federal
is all
dollars.
100% federal?
Yep.
Okay, thank you.
Great.
Are there questions, Representative Daniels?
Thank you. In raising children, I understand that there are always times where behavior
Yeah.
comes into play. So how does one determine when a psychiatrist is needed?
That's a great question. Thank you. And I'm not a provider, so you're going to get the non-clinical answer for that. But in this particular program, we know that moms and babies tend to show up at those well child visits through childhood, and parents will describe behaviors that are concerning. There are validated screening tools, and so part of what this program does is make sure that those primary care providers, those, pediatricians, their regular pediatrician, have the tools they need to help determine what's regular behavior and what might be something that's more concerning. And so, they use their clinical expertise as well as the standardized evidence-based screenings to help make those decisions and then provide the referrals when needed. Much like, I would frame that much like when, those of us who are older go to the doctor and say, we might, my blood pressure might be raising, and they will make that decision through their series of clinical assessment and screening tools of when you need to go to a cardiologist versus being just treated at your primary care provider. Same thing.
Okay, I guess my concern, it almost sounds like you're trying to fit every child into the same box. And well, we obviously know that children are different from one another.
100%. And that's really that's the art of the clinical work, is to understand what's within the normal range of development. And all kids develop differently along the way, and what could eventually be something that requires more intensive care. So I agree with you 100%. Kids are they're all unique, but the clinicians are trained in their medical practice to understand what's within the bounds of normal or expected or typical, and then what might need additional care.
Representative Jaworski?
Thank you. I just have a quick question, and this is just something I'm curious about as I'm thinking about it. My children are all in their young 20s. And so over the course of a decade, as they went through their primary care visits, there was an introduction partway through with my middle child and younger child of like a screening tool on depression, anxiety, which my older child didn't get. Is that something that would have come through your department to implement that, or is that more of like training from national best practices?
Oh, both, 100%. So certainly best practices would inform that. AAP, the American Academy of Pediatrics, certainly takes a position on what really is the best practice. They have something called anticipatory guidance for pediatricians, where all the smart pediatricians get together and say, this is what you should be talking at every one of those well visits, and these are the sort of tools you should use. The way Division of Public Health supports that is to provide additional training where needed at times, and also to set expectations sometimes for community health centers that may receive specific funding from the division to say, oh yeah, there's that developmental screen. We would have an expectation that you do developmental screening at these particular milestones.
Thank you very much.
Great.
Okay, so the rest of your presentation looks like good subject matter material for us to be smarter in public health. Would you be able to summarize and hit the high points and make your
Sure.
main points in like 10 minutes or less?
I will do my best. Thank you. That's a lot of slides, but I can do that for you.
I'll give you a heads up. On 23,
Yes.
you have these arrows connecting to one another.
Yeah.
And what I'd like to know when you get there is, are those arrows? It makes it appear as though they're all full and intact and everything's working like a machine.
Sure.
I'd like the little nuance behind that.
We
Like,
can get to that.
What needs to be built? What is broken? You know. All right. Thank
Thank you. I really appreciate that. So I'm going to fly through, and I'm always happy to take questions on this later on. I appreciate the need to get out of here early today. So where we're starting on slide 17, and again, you can take a look at this at your own time. There's an idea of something called adverse childhood experiences. And these are experiences such as abuse and neglect, some household challenges that have been found to correlate with some negative health effects as people become adults. So if a child experiences physical abuse, emotional neglect, has household challenges of a family member incarcerated, a parent who is treated violently through domestic violence. There was a study, a landmark study of over 18,000 adults in the Kaiser Permanente health group that when studied, that those with some of these negative health outcomes, mental health concerns, risk-taking behavior, substance use, even higher risk for HIV, infectious disease, and chronic disease, even heart attacks, can be traced back in some way to the more of these adverse childhood experiences you have, the more likely that you might have some of these negative health effects. I present this here simply because it's the reason and the rationale for a public health approach, that these are not just individual one-offs, that in general, there appears to be some robust correlation between these experiences that happen to children and adult health and adult behavior. This also has a generational effect, as you have parents who may have experienced these things as children who are then parenting their own children. So in New Hampshire, these adverse childhood, experiences are incredibly common. Over 64% of females in high school, almost 50% of high school boys report at least one of those adverse childhood experiences. As you look at that list, that makes sense. There are things on there like divorce. Absolutely. They may have experienced one of those. As adults, we also know that about 6 out of 10 adults have also experienced one or more of those adverse childhood experiences. But where the rubber hits the road is when you experience a lot of them. That's when the cumulative effect happens. More adverse childhood experiences, higher risk of negative health outcomes. So if you have an ACEs score, they're called ACEs, of 5 to 8. So if you look at that list, if you check off 5 to 8 of those things, it indicates a significantly higher risk for developing a range of physical and mental health conditions later in life, including depression, substance use, chronic disease, heart disease, cancer, and a shortened lifespan. So when we look at where our teens are today, we see about 1 in 5 have between 3 and 4 ACEs, and then a much smaller number, to Representative Daniels' point, who might have had a lot of those experiences. And oftentimes those are kids that have likely come through our Division for Children, Youth, and Families, or who are needing to access highly specialized behavioral health programs. So I'll skip over public health's role in that, but it's really because the reason public health gets its nose in this business is because we want to prevent those long adult outcomes. We also don't want any kids to be suffering as well, but we have a role in preventing chronic disease, behavioral health problems, substance use. So what can you do about that? I think that that's a question that I know that others have asked. And there's a thing also, so you have adverse childhood experiences. Those are all the negative things that could have happened to you. But you pair that with something that I think is even more strong, and that is our protective factors. And so all of us can think in our minds of a person or a family who had a lot of horrible things happen to them as a kiddo, and yet they've sort of come through that with incredible strength and resiliency. And oftentimes what you can match that back to is some accumulation of these 5 protective factors around having social emotional competence. You can recognize and deal with your emotions. You have knowledge of parenting and child development. Again, if you're a parent, if you learn about parenting, even if your experience as a child was less than optimal, but if you learn and grow into understanding the best ways to parent in order to support your child, that's a protective factor. Social connections. We talked about this last time. You can't, if you're isolated, whether you're a young parent or an older adult, we know that puts you at higher risk for all sorts of negative health outcomes. And then, of course, at the end of the day, there are those concrete supports. Do you have housing? Do you have health insurance? Do you have food on the table? All of that, if you've got those things, it helps to make you and a family more resilient. And so this is where public health comes in with some of those programs. You can flip to page 22 or slide 22, and you see that triangle that I shared the last time. Again, we spend a lot of money right now on those individuals that have this really high need for services, and we spend that money in residential care. There is a suggestion, and I think data to support this, that if you right size that triangle and spend more time, again, if you think about a parent who had those negative adverse childhood experiences in their childhood who are now taking care of a new baby, if you spend a little time talking about building connections, building parenting skills, you have an opportunity to interrupt that generational pattern.
So
I'm getting to your slide.
May I think Representative Priest had a question, but I want to, for transparency to the public, I just want to say that it's mine, and you can correct me. What I want to say is that we are looking at a current situation where we invest heavily in sort of the high-end, more expensive interaction with providing care. And the theory is that if we had invested differently and we had put more money into prevention, that we would have saved money on the back end. And so to the extent that there's a proposal to shift resources, the challenge that we're going to have in this budget year is you still need the money to take care of the people in desperate need. And then you would need to find new money to be investing in the preventive side. And I think in this particularly budget challenged year or 2 years, that's going to be very difficult for us to be able to really do that. And these ideas represented here, I think, are very good, very solid. But I just keep hitting the dilemma of how we're going to do both things with the same dollar. And so Representative Priest, that was more commentary than anything, because am I wrong?
I think the challenge in front of you is to look at the pie that you have right now and determine how you're going to spend that, understanding there aren't going to be more resources. And so where do you strategically invest? It is the challenge that comes every 2 years as you build a budget. And I appreciate that this year is going to be particularly difficult. But what I would suggest is, as we think about it, if you pull from one string to balance something up here, there may be unintended consequences later on. It is a challenge always in a biennium budget, because you may realize those costs may come later. and they're not going to come in this biennium. So that's why you all are smart and at the table, and you put together your budgets understanding that.
So I do hear you. I think we are smart, but this is this is an environment where experience really matters. And having walked the trenches with your boots on the ground, you have information and knowledge and insight that we'll never have. And so we're going to have to rely on you to tell us where the strings are.
Yes.
Okay. Representative Priest.
Thank you, Mr. Chairman, and thank you for taking my question. It goes back to slide 17 when you break down the adverse childhood experiences. And the one in particular, household challenges. Shouldn't there have been a circled emphasis in the environmental lead poisoning as being very significant? Because if a child has lead poisoning, his whole mental growth is
I fully,
diminished.
yeah, I fully appreciate, and we have, and this general court has been very supportive around lead poisoning initiatives over time, and I can't overstate how important that is in a state like New Hampshire, where we have such a significant number of homes built before 1970, and quite frankly, many of those that are in substandard conditions, so that paint is available. So it was not part of this study. I could spend some time thinking about that, because this was based out of California, that does not have quite the same lead exposure risk that we do here in the Northeast, just because of the age of our homes. Thank you. So
Representative Tversky.
This is sort of somewhat connected to that. I was expecting to see a circle that said poverty and how the interconnectedness of poverty for families. And I just don't know how that comes into discussing ACEs or not.
typically it hasn't. I mean, I think it comes in when we talk about protective factors, really. That's where we see the impact of poverty and whether some of those impacts can be mitigated by food, housing, access to TANF, access to SNAP, access to WIC. That's where we can see that if those needs are met, we have a better chance of making sure that families are more stable and the children ultimately are more independent of those social services.
Great, thank you, that helps.
Representative Priest.
Going along with the previous question, excuse me, thank you, Mr. Chairman, and thank you for taking my question. Going along with the previous speaker's question, I also agree that poverty needs to be emphasized, given the fact that there has been a rise of homelessness in our major cities and all of our communities, and it has definitely affected the childhood.
Absolutely. And again, a protective factor when you've got those basic, those of you studied Maslow's hierarchy of needs, you've got to have that basic set need of your housing and your food, and you've got to have that stable so that you can do the emotional regulation and the hard work that is parenting. As any of you who are sitting here who are parents know, it's a hard enough job regardless, but if you don't know where your next meal is coming from, it becomes that much harder. So if we...
Representative Daniels.
Thank you. What is your success rate of your protective factors overcoming ACEs versus people remaining dependent on the government?
Sure. So, we know that programs, and we can talk about that actually right now on slide 23, programs like home visiting, there are some outcomes around there that if once people have these home visiting programs where a trained person, usually someone from the community, comes in and talks about parenting, connects people with services, we know that there are fewer, I'm going to look at here, there are better birth outcomes. So that's first of all, great, because that's less money to Medicaid if you have a better birth outcome. You have kids are going to their health screenings. Parents are better able to cope with stress better, that they're more likely to enroll in school. The parents are more likely to enroll in school training. And so that gets to those protective factors that ultimately sets that whole family up for independence at the end of the day, especially as you want to make sure that both kids are attending school and that the parents are getting either the school or the training they need so that they can be independent. Thank you. So as we look at slide 23, we've got 5 programs here, and they are part of a system, which is like that little choo-choo train of arrows, because this is the family support programs that are within the Division of Public Health Services. A reminder back to that 2018 time, some of these were in other areas of the department. They're now all nestled together, organized under public health in partnership with the Division of Children, Youth, and Families and our Division for Behavioral Health. And we have 5. One is our Family Connection Center. This is funded by general funds, and this supports families where a parent is incarcerated. And so there are family resource centers built into the state, men's and women's prisons. And this enables connections between that individual who is incarcerated, that resident of the correctional system, and their children. Because we know many times those moms and dads are going to leave corrections. They're not, most of the time, they're not there for the rest of their lives. And they're going to be a part of that child's life going forward. And so you want to optimize the ability for them to be an appropriate parent. And part of that is building that connection. So if you think back to that ACEs list, a parent incarcerated really can put kids on a trajectory, can be one of those adverse childhood experiences that have really strong impacts on that intergeneration of mental behavioral health, substance use, and risk-taking behavior. So if you can come in right then while mom or dad is incarcerated and build that connection and teach some healthy parenting while they're incarcerated, that can be really helpful when they go back. Even if they don't ever go back, or even if they no longer even have full custody of their child, simply having a relationship is helpful. And that looks like reading bedtime, like recording bedtime stories. It looks like having FaceTime visits. And so these funds help that happen. We have our home visiting program, which is really one of our flagship programs for providing support for children and young families. We have a Healthy Families America program. It's all over the state. It's very evidence informed, both nationally and locally, and we can track the evaluation. It serves a relatively smaller number of families because it's pretty intensive. You enroll while you're pregnant, and it's completely voluntary, but you enroll while you're pregnant, and you have a home visitor who does parent education with you until your child is 3. So it's not a one and done. That's an ongoing relationship, very effective. The general court added HB2 money to add to our ability to serve more families in the last biennium. We have child and family health supports, which is like home visiting and often uses the modality of home visiting. Someone goes out to somebody's home, but this is really more episodic in nature and really is designed to meet needs when they need them. And is highly connected to our Division for Children, Youth, and Families and our Family Resource Centers. And this uses a mix of federal funds and a little bit of general funds. We have something called Kinship Navigator. As we all know, we've got more, and I talked about last week, we have more and more families, grandparents, aunts and uncles, others taking care of kids that are in the DCYF system. This Kinship Navigator is a person who can help that family member navigate what it's like to have a kid when they, again, grandparents, it's been a long time since any of us had a little kid in the house. Helps them navigate systems. That is supported by federal and general funds. And then finally, we have our family resource centers located all over the state that coordinate some of these efforts and are a place for families to have that kind of parenting education and build the connections that they need so that they can be stronger parents. And that is generally supported by general funds. So I've gone over my 10 minutes. There are slides that talk about these programs a little bit more in detail if you want to learn more about them. But at the end of the day, what I really wanted to leave you with is this notion of, across the department, we are working very hard. And in my role as an associate commissioner between DCYF, public health, behavioral health, is to coordinate all these efforts so that we can align prevention. We can centralize places to call for help, whether that's your pediatrician's office or something much higher needed, also for even the pediatricians themselves. We want to make sure that we have our helpful services at the appropriate scale. So while we serve 300 families in that intensive home visiting program, is that enough when you think about the number of families that could be served? We want to strengthen supports that kids and families stay home I want to reduce the reliance on residential care. It's one of our key initiatives is to reduce that reliance. It's too expensive and it's not always great for kids. It's better for kids to be in families where it's cheaper and they have the sort of social emotional support that they need. And again, our job is also to coordinate expert care and finally measure progress to see if any of this works. So you need the data in order to measure progress. I have gone over my allotted time.
No, you said an hour. It's been less than an hour, so you did good. So, Representative, is this, the Associate Commissioner wants to step away from the table. Do you have a question?
Yeah, I have a quick question, and that is on that chart. What do the trend lines look like in each one of these, in each one of these arrows?
So there's several questions like that maybe we can address by looking at what you're putting in the coloring book.
Yes, thank you.
okay.
And could you refer to the exact slide that you're
I'm
pointing at?
looking at slide 23.
Yes.
It gives specific numbers for
Yeah.
how many, and so I'm interested in what the trend lines have looked like in each one of those
Great.
boxes, up, down, flat.
Super,
So,
thank you.
And I'm sorry because I'm not familiar with the coloring book since this is my first term, so I'll.
It doesn't exist. It's my nickname for a beautiful presentation they put together with tremendous information in it. It's a derogatory term out of huge deference to the work and quality of it.
I was just wondering whether I should bring my own crayons. So.
It never hurts. I can't afford to give you any.
And right now, I don't know if we can afford to give you color copies anymore, so you enjoy it while you have them.
So, Representative Mooney?
Just with regards to those coloring books, the complete set of hard copies is in my office. Anyone is welcome to come in and see them. And also, they are online. The LBA tab on the legislative website under last year's or last term's budget, the full complete set is scanned in. So a few ways to access those, and they're very carefully well done. Thank you.
Thank you.
Representative Stringham?
Just a clarification, those are last term's coloring books, correct? Not the ones we'll get this week.
That is correct.
Mr. Chairman?
Representative Daniels?
Yes, first of all, thank you so much for the presentation. A lot of good information here. One thing I would have liked to seen a little bit more of, since you want to focus more on the preventive side, when we take a look at slide 17 in the different things of abuse, neglect, household challenges, I'd be interested to know how you're planning on addressing those, because I think that's what you're trying to accomplish is to stop those so it never gets into the system.
Yeah.
But I didn't see a whole lot on the preventive.
So I think, and part of that is a little rush for time, but those home visiting programs in particular are designed to reduce entry in the child welfare system. So that's one example. That Child and Family Health Supports, again, is designed to reduce entry into that child welfare system. And there's a little bit of data. I think, let me look at the slide if I added it. So if you look at slide 26, you can see in the child and family comprehensive family support systems that of the 1,700 kids discharged from that program in 21, 76% had not had an accepted investigation in 3 years. That's where the proof, that's where the rubber hits the road, is those programs. Now, we can never say fully it was that program, but that gives us encouragement that those sorts of things help keep kids out of the system in the first place.
I guess what I'm looking for, and maybe there's something online that I can look at to say that a home visit is going to do something. I have no idea what happens in that home visit.
I would love to take you on one someday if you'd like, but we can provide more information. Again, just given the time, I didn't want to dive too deeply, but we would love to spend more time talking about those because it's really, again, a good investment early on to keep kids out of the front door. We talk about, the front door of DCYF. This is keeping kids out in the yard, far away from entering into the system, and that's what we want more of.
Okay, thank you.
All right, I think you're done with our questions for now. So thank you so much. Appreciate it.
Thank you, and thank you for the opportunity to talk about this. I'm always happy to talk more offline.
All right. So who wants to go next?
Oops, I'm here. I'm not graceful, so that is one thing you will learn about me. Good afternoon. I'm Chris Santinello. I am also an associate commissioner here at the Department of Health and Human Services. I was originally supposed to present with Associate Commissioner Tilly about a week and a half ago, but I ended up being ill, so I appreciate the opportunity to follow Tricia today. Want me to, I'm just gonna get into it. Okay, so I want, if you look on slide 2, we have a little bit of an agenda here. We're gonna first talk about developmental services, then go into healthy aging, then discussed our home and community-based waivers, and then a little bit on financing for Choices for Independence and nursing facility.
So how much time do you think you need?
How much time would you like me to
No,
need?
well, I'm just curious. You've got this in your head. How much, if you just.
So
spoke-
when I practiced this yesterday,
Yeah.
I needed 33 minutes, but that wasn't with any questions.
Right,
'Cause-
right. Those questions, those
So-
darn questions. So is this the only presentation today? After this is it, right? So, okay. So you're on.
I'm on. And what I thought I would do is maybe go through each section and then at the end of each section, pause to see if there's questions, because if that works for you, that. Okay, so this next slide, you're going to see a similar slide. Associate Commissioner Tilly used it a little while ago. We used it again when we met a week and a half ago, and then when we did the department overview. And it's just really showing how we meet the needs across the lifespan. Today, I'm going to focus on older adults and some of our specialized populations. I think one of the things within our department, as we have talked about here, we are a large department, but yet we're able to leverage and connect individuals and families with multiple programs pretty seamlessly. So within developmental services, is it okay if I keep on going? Okay. I've been with the department since 2016. Prior to that, I actually worked in the developmental services system for over 25 years. And I think that brings a advantage within the department because I understand the history of that system, the complexities, the people served, and most importantly, the people that serve them. So I think that brings a good perspective to us here within the department. You will see on the next slide, it's slide 5, the operating structure of developmental services. And I think it's important as we begin talking about the different services system that you understand how the system operates. This is a little bit different than the last time we presented to the budget because we did have a change on July 1st, 2023 with how we operate. But if you look in your left-hand corner, all of our we get funding from the federal government through the Center of Medicare and Medicaid Services, and it is a 50-50 match. We use 50% general funds to get 50% federal dollars. Those funds flow to the Department of Health and Human Services. We work together closely with our 10 area agencies. We have 10 area agencies throughout the state. They are private nonprofit organizations, and they're designated through the department. They actually provide with DHHS a shared governance for the system. We work together for quality initiatives. And also through the area agencies, they determine eligibility under 171A. So if people apply for services, that is done through their local area agency. In turn, we have service coordinators, and their role is to assist individuals and families with accessing services that meet the needs and the desires of that person. And then in turn, we have provider agencies that provide many of the direct services. What is unique is the provider agencies must be enrolled as a Medicaid provider and have the option to bill directly for services. An agency, whether it's a service provider or an area agency, can provide direct services. They can also provide service coordination. They just cannot do it for the same person. So that's very different than how the system used to be.
Okay, so you say we have 10 area agencies and they've been designated by DHHS. So the first time people hear that, they may think, well, we got 10 counties, we have 10 area agencies, but the correlation isn't exact, right?
Correct.
Right.
They
So
cross over.
that gets me to the question, why 10? Is 10 a magical number? And would we save money if it were 7?
So there used to be 12, and back in around 2004, 2006, we went from 12 to 10. And I think you and I have had this conversation a little bit. If we went from 10 to 7, I don't think you would there would be any savings. It would be very minimal because area agencies are paid through a designated area agency rate, and that is based on the individual receiving services. So that would continue regardless as to how many agencies you had.
Good answer. So
Thank you.
service coordinators. Do we have an approximate number of how many service coordinators we work with? It feels like 80, 90, something.
No,
like
there's about 80, 90 service providers. There's less service coordination agencies.
Okay. And that the number of service coordinators probably doesn't have a direct budget impact because the money that pays them
Is billed.
is basically built into the fees that are being transferred.
We have a rate for service coordination. We have a separate Medicaid rate for that. So correct.
Right. So if somebody's looking just grossly at how we can make this more efficient, changing the number of area agencies, trying to change the number of service coordinators, this would have very little impact.
Very little impact.
Okay, and it could do some harm, right?
Yes, I
take
believe so.
capacity out of the system.
100%.
Okay, and then tell the provider agencies. Tell us again, or tell me again, what we mean by a provider.
So that would be
agency.
somebody who provides the direct service. They could provide day services, supported employment. Some of them provide residential services. So it's the services that is outlined in someone's service agreement. The service provider is the one that would provide that.
All right, thank you.
You're welcome.
Any questions there? No.
So next I'm going to turn over to our roadmap. And one of our goals under commitment 2, under promote thriving communities, is to strengthen the developmental services system. On the next slide, I'm going to talk a little bit about where we've been, but this is where we want to be going. And really, if you look at the middle part of this circle, you see an individual and they have outcomes. And what the values we ascribe to within the system are choice, uniformity, sustainability, and quality. And then the outside ring here are what is needed to support that within the structure of developmental services. So what does choice mean? That means that the individual has a choice as to who will provide their services, what services they will receive. Oftentimes, maybe the staff person that will provide that. Uniformity means where you live should not matter what services are offered to you, that it should be the same. If I live in Claremont, I should have access to the same services that someone in Concord has. Quality is what we're providing of quality. Are we hitting the mark? Are we doing what we said we would do? And then sustainability. And I think that's where you were kind of going, Representative Edwards, is are we using the funding that is committed to this system? Is it based on actual costs? Can we predict it for the future? That's where we talk a little bit about sustainability. The next slide, we talk a little bit about where we've been and the investments we've made in developmental services. from about 2016 to 2023, we were under federal compliance with a corrective action plan. And I believe we talked a little bit about this in the last budget session. We were out of compliance for a direct bill provision, as well as conflict of interest in case management. We have met this compliance. July 1st, 2023, we were found to be compliant in both areas. And so what that means is we had a number of initiatives we wanted to do to strengthen the system, to think about the future for individuals and families, but we couldn't get to it until we put compliance behind us. And so we took a pause in 2024 instead of moving right towards system strengthening, of stopping and listening to individuals and families and the providers that support them. So we came up with shared values as to what's important as we move forward in the developmental services system. We had a number of family forums, we had a number of information sessions, and we had a number of surveys that we did to say, hey, what's important for you as a family member as we move forward to strengthen the system? Service providers, what's important for you? For area agencies, for service coordinators. We worked with everybody to make sure we all came to agreement on what our values going to be moving forward and what are the priorities that we need to work on for the system, which you will see on your next slide. Get a little sip of water here. So we came together, and the 4 primary areas that actually overlaid between individuals and families, service providers, area agencies, all had these 4 areas in a core. And that was communication and information. How do individuals and families access information? How can we as a department provide them with information? Prior to having some of the IT changes we made, the department didn't have that capacity to communicate directly with individuals and families. We updated our website to make it family friendly so that the information they need is on our website. We decided that we really need to invest in our workforce. This is an area where it's people helping people. If we don't have the people to help the people, then people will not get services. And so we did a number of things. We, using 100% federal home and community-based reinvestment funds, we distributed about $15.6 million of federal funds to help 45 organizations develop workforce grants to focus on retention, training, and ways to recruit staff. We also worked on training and development. What type of training do providers need so that they are able to meet the needs of the individuals they serve? And then access to services. What is included on our waiver? How do you access the waiver services? And provided some of that information so families understand better what they can access.
Of those workforce investments, what seems to be absolutely brilliant that we're glad we're doing? It's so obvious it's paying off.
I think there's a whole bunch of different ones, and I know Melissa Hardy is collecting a lot of that information, but some agencies have done targeted recruitment. Like I've seen ads on TV to try to access, to really show this is the work of a direct support professional. This is why it's important to me. Other ones have invested in training and bringing on credentialing some of their new workforce so that they stay and are invested in the organization. So there's a whole variety. We can actually provide you a summary if that would be helpful.
Okay, and then implied in the way I phrase that question is, are there any investments we've attempted that don't appear to be adding the value we had hoped for? And we don't need to talk
Yeah,
about
I don't
that
know off
now.
the top of my head, but we can get that for you.
All right, thank
Yep.
you. Representative Daniels?
Thank you. In response to the survey that you do,
Yeah.
what's your response rate?
It was actually, it was probably, it was around 500 individuals and families, but that was on top of the actual forums that we had.
Okay. And it's just something that's put out there where someone can go and,
Yeah, what we advertised it really well. We talked about it in any of the sessions we had, so we tried to make sure people filled it out, you know. But we also did a lot of work with having individual forums in the different parts of the state, and it was really important. And we used a location where department staff could be there and to hear from families. And that's where we got a lot of really good information in those one-on-one conversations.
okay, thank you.
Okay. So our next area is on the next slide, and it's really looking at assessment informed rates as a commitment to uniformity. And so one of the things within our developmental services system is we do not really have a systemic way to match an individual's need with their service authorization, which makes it really difficult for us to ensure that everybody's getting the same access based on their needs. It also makes it really difficult for us to predict our budget moving forward and to use our taxpayer dollars in the way that they were intended. And so one of the areas that we did is we had an assessment a few years ago, and it was shared with us that if we move towards potentially doing assessment informed rates where somebody's need is tied to the resource allocation, that is a way for greater efficiencies. It creates standardization across the state, but it also helps us predict our dollars more effectively. So we are starting to go down that road. But as part of that, we had to develop rates. And so over the last year and a half, 2 years, we have worked with a contractor, Myers and Stauffer, to help us develop rates. What is the true cost of services based on cost reports if you put the individual providing the services at the center? Because in developmental services, in many of our helping services, you really need to understand what is the cost of the worker to do the work. And so we have had significant stakeholder engagement. We've had about 39 to 40 different rate work groups that includes providers, individuals, families, area agencies, service providers, all around looking at how would we develop rates. We have put in as a prioritized need in our agency budget the cost to phase in those rates. And I think Representative Edwards, when you were talking earlier, when Commissioner Tilley was presenting about, you know, some of those preventative services, how we phase in the rates if they were funded is we would be starting with those services that helps keep an individual at home with their family. So services that help people to stay independent and need less costly residential services. So ultimately, our goal would be by increasing those rates, making that attractive for providers to participate in, more and more people hopefully would take advantage of some of those lower cost services, thus delaying the need for more costly services. Our goal would be over time, this would actually stabilize the budget and not have it be such an increase every year.
Representative Daniels?
Thank you. Does the client contribute to the cost?
The client covers their own room and board. They cover some of their spending money, some of their other benefits, but aside from that, we bill Medicaid for the actual services.
Representative Stringham?
So these rates are all within the developmental disability waiver, is that correct? And are they similar to any other services, any other Medicaid program?
So how if we were to get these rates, we would then put them into the Medicaid waiver. As part of our work to develop the rates, you have to ensure parity with other services that are similar in another part of Medicaid.
Okay, thank you. Are you finding anywhere where the rates are generous? Or is everything kind of more likely to be increased in cost than decrease?
Yeah, there wouldn't be a decrease.
Thank you.
But I guess there wouldn't be a decrease in the rates, but when we move and implement, if we are able to the assessment informed rates, we would better be able to align with what a person's assessed need is with the service authorization they receive. We don't have that mechanism today. So I can't say that, okay, if these were to be funded, you would see a change immediately, but I do believe you would see a change over time.
I think what you would also see, as Chris had alluded to earlier, is less variability. And I think in the long run too, when it comes to the budget, accuracy is really important so that you don't over budget. And by having more standardized rates, that would allow us to budget more accurately. So maybe you would have extra money or money that you wouldn't need to budget because you'd have a higher level of assurity there that could be used elsewhere. So it's not necessarily only the question of are you going to spend less, but are you going to budget what you're going to spend, I think is really key there. And that's been one of the challenges historically.
Because we have to reserve that money, right? For this
Correct.
program.
Yes.
Thank you.
So I'm looking at the fourth block there where it's got the bullet that says with budget approval. And I'm thinking about what I think I heard you say when you said that in order to do the rate phase in, you may need some additional money and that additional money will show up probably in a prioritized need.
Yes.
Okay, so when the time is right, I'd like to really understand why you need money to do a rate phase in.
Okay. I think Melissa will definitely include that in her budget presentation, but we can also sit down and review that if you'd like.
Yeah, because my simple thought is you take this rate and you turn it this way, and take this rate and turn it this way, and then boom, you've got your rate adjustment, and that didn't cost you anything.
Okay.
So it's got to
Well,
be more
I think
complex.
but don't forget when we developed these rates, we actually received cost reports from providers. We worked with providers to say, what is the cost for a direct support professional? So some of these rates we would look to phase in early, haven't been looked at for years.
All right. So we have something to look forward to there.
Yes, you do.
Yes, sir.
I think one important thing, particularly for new members, when we are talking about the DD budget, there's 3 accounts, and for the current biennium, it's total funds of about $900 million. So when you are looking at the HHS budget, I think it's just important to recognize that this is a large portion. So when you make adjustments to a rate here or there, when we're talking about it, this area being a large dollar amount, that will have impacts to a higher degree than some other areas.
Okay. So that's developmental services. So before I move on to healthy aging, do you have any other questions?
I do.
Okay.
Would you feel comfortable hearing the DD community, the DD part of this budget described as the part of the budget that attempts to address the needs of New Hampshire's most vulnerable citizens?
I would say individuals with disabilities are some of New Hampshire's most vulnerable citizens, yes.
All right. Thank you.
Okay. So now we're going to move on to healthy
Sure.
aging.
Go
Okay.
for it.
So, healthy aging, if you see this first slide, this is demographics as to why do we need to focus on healthy aging as a state. New Hampshire is the second oldest state in the country, has as long as we've been here, but demographically. And nearly 20% of New Hampshire's population is age 65 and over. And 35% of our population is age 55 and over. And so it behooves us as a state to focus on how do we support those that are older adults to age in place at home, receive the services they need at home, and delay any further more extensive services. And so in the last budget, we received funding and a charge to develop a system of care for healthy aging. And really what that system of care of healthy aging, which is described visualized on the next slide, is a comprehensive and coordinated system of care that promotes healthy aging and enables adults who are older and adults with disabilities have meaningful choice in care options in their homes and in their communities. And if you look at this little visual here, this is the vision for the system of care for healthy aging. And it's not just what the Department of Health and Human Services is using as a visual, it's also what the State Commission on Aging is using, what the Alliance for Healthy Aging is using, so that we're all working together with a common goal. And if you look at the outer circle, there's a number of services and supports. And some of these services are preventative in nature. And so I think about the meals and nutrition programs. In 2024, through the department, 15,000 people received Meals on Wheels in the state. Of those 15,000 people, 61% of them said that was their primary source of nutrition for the day. And also, of those 15,000, 41% said the driver who delivered their meals was the only person they saw during the day. So again, it's one of those social programs that has a focused area, but it does such good to support older adults in our state. We also have in this outer circle abuse and neglect prevention. And we do that in the department through our Adult Protective Services program, which is authorized under RSA 161. And it really ensures that vulnerable adults are not subject to abuse, neglect, and exploitation. And so you see how some of these services in the outer circle, and we use a combination of funding, whether it's state general funds, whether it's old age assistance, whether it's Older Americans Act dollars, Administration for Community Living, to really wrap services around somebody. And then as you go into the green part of the circle, those are locations that maybe is out of a person's home. And so that the services on the outside weren't enough to keep somebody at home. So then we needed more services, whether that's through our nursing facilities or our Choices for Independence waiver. Some of the work on the system of care has also helped us to ensure, what you will see on the next slide is we had to make some financial eligibility changes, made it a little bit easier for people to access Medicaid services. We got rid of the spousal impoverishment, which basically means that previously, if you had a spouse that was living at home, they had to actually become impoverished for their spouse to get services. And we changed that, knowing that that's really not the right thing to do.
Who's we?
It was actually the state of New Hampshire, as outlined in HB2 last year.
So that's an HB2 item, so it's law now. Is that ongoing, continuing law, or was that just for
Ongoing,
the budget?
continued, yes.
Okay.
We increased the resource disregards. We also changed the look back period. So prior to HB2, if you applied for Medicaid, you had to provide 60 months of financial documents. So think of yourself if you are trying to help a family member. to come up with 60 months of documents that you may not even know, accounts that your parent may have had. So and that was a barrier for people to access services. And so through HB2 with the system of care, we're allowed to go back 36 months as long as if we do these data scans through a verification system. As long as there aren't any red flags, we can go ahead with the 36 months, which really helps people get access to services quicker.
Representative Daniels?
On the Medicaid eligibility, isn't it still 5 years to get connected to Medicaid on the look-back period?
We've switched that to 36 months as long as there isn't, when we do our scans through the databases, that it doesn't look like there was a transfer of assets. So if something is a red flag, we will go and look beyond the 36 months, but for the majority of people, it's 36 months.
Is there a federal eligibility requirement that people have to buy into?
We received federal approval to do the 36 month look back.
I'm just wondering if somewhere along the line there isn't different qualifications, 36 months for the
Right.
state or 60 for the federal.
We're allowed to do the 36 months with the
I
federal approval.
understand what you're
Right.
saying.
Okay.
I'm asking, is it still a requirement federally of 5 years?
So when the law was written in HB2, they amended RSA 167.4, and in the state law it said to the extent permissible by federal law, where they changed it from 60 to 36 months, and we've since received approval. So currently it is compliant.
Okay.
Anything? Okay. We also were required to do a Choices for Independence rate study to look at the rates for our Choices for Independent services to make sure they're competitive to keep people at home. We made a number of changes and are still working on the changes to New Hampshire Easy, which is our gateway to services, to ensure that individuals, their caregivers, and families can actually access through our provider portal. And we've been able to use 100% federal funding to enhance New Hampshire Easy. And finally, we expanded who could be a provider of personal care services. Any questions on that? Okay, so I'm going to move now into our home and community-based waivers, if that's okay. Under the Division of Long-Term Supports and Services, we have 4 home and community-based waivers. These are 1915C waivers. They are voluntary. We have to show in the aggregate of the waiver that it is cost neutral, so that the average cost is less on the waiver than it is in an institution. That is required by CMS. We have 4 different waivers. We have the Children's In-Home Support Waiver, and that is for children birth through the age of 21. They must live at home with their families, and they have to still be in school for this service. It is family directed, which means the families really direct how the services occur in their home, and all of the services are based out of the person's home. We have our developmental disability waiver, which is our largest waiver, and that is primarily those who have exited the school system. And that's where someone will receive day services, residential, respite, employment, services to remain independent. And then we have our acquired brain disorder service waiver, and that's for those ages 22 to 60. So that, I know it's confusing, right? So that means that their brain injury had to occur after the age of 22. If it occurred before that age, then they would be served under the developmental disability waiver, because that would be considered a developmental disability because it occurred while you were developing. And then it ends at age 60 because then you would go under the Choices for Independence waiver. And then we have our Choices for Independence, which is our aging and older adult waiver. Any questions on these? Okay.
Sorry, I have a quick question. Can you just explain to me the average cost per year column? And what
Yes.
those figures mean?
Yep. So if for the 460 children on the in-home support waiver, the average cost is about $14,000. That waiver is capped at $35,000, so it cannot exceed that amount. Developmental disability, we serve just under 6,000 people, and that average cost is $73,000. There are a high number of residential services on the DD waiver, which actually makes the cost go up. That is one of the areas when we talked earlier about the rate work that we want to get standardization and uniformity to really look at some of these costs. Okay.
Representative Stringer.
Yeah, and then how many in the other two programs?
So on the acquired brain disorder, we serve about 235 people. And for CFI, about 3,900, sorry.
And just in digging into the rates, is there any, my understanding of the way these things work is this is a service somebody needs, and this is how much it costs. And I can imagine that there are services in there that are relatively inexpensive that they may find extremely valuable, and ones that cost more that, maybe they don't feel as strongly about. Is there any ability within these waiver programs to tailor them somewhat so that the cost to the state may be lower, but the value to the recipient would be higher?
I think that's where we were looking at some of the rate work. And when Melissa presents later this month or early next month, she can kind of go over some of those. But we really want to incentivize or encourage some of the services, the rates that keep people at home, keep people independent. And right now, those rates are really low, but we think there's great value to them because the longer somebody can stay independent, stay with their family, live on their own, then they're going to need less residential services down the road. So over time, definitely.
Representative Priest.
Thank you, Mr. Chairman, and thank you for taking my questions back. On page 15 again, the number of people that you have been able to provide service in-home supports, what was that?
Oh, sorry, that was 460 children and families.
Okay, and what about developmental disability?
5,939.
Thank you.
You're welcome. So one of the questions I think you had prior to us presenting is how do we measure performance? And I know Meredith Toulouse was here talking about the Division of Program Quality and Integrity. And so there's many ways that we partner actually with that division within the department. So you take the program staff who really understand the program, you take the program quality and integrity that understand quality, and working together, how do we ensure the services we provide are quality and that we're doing what the individuals and families need. So we have a variety of ways that we measure performance. I won't go over all of them. You have them on your slides, but because we have a Medicaid waiver, we have to provide certain financial and service quality assurances to the Center for Medicare and Medicaid Services. We do file reviews, we do governance audits, we have providers report adverse incidents that happen, and then we have follow-up to make sure that doesn't happen again and the incident was corrected. Through developmental services, we use the National Core Indicators, which actually measures a person's experience receiving services, because that's really important to understand. And then we just started doing that for the Bureau of Aging and Adult Services. We also make sure that services are provided as authorized. Was there an authorization before a service was claimed? And then were the actions taken to make sure that complaints are resolved? Questions?
Yes, thanks for taking my question.
Thank you.
On slide 15, so just so I'm clear, this is represent what year?
This is fiscal year 24.
Fiscal year 24. And the same kind of a question, the numbers that you have here, are they relatively stable over a period of years? Are they increasing, decreasing in these categories?
So-
Or is that something I can find?
We do, you will start to see on the fiscal dashboard, the developmental services numbers. We had to take a break because we had some IT system changes. The acquired brain disorder population stays pretty consistent. The children's in-home support is also pretty consistent because we just have a limited amount of services. Where you'll see growth is through developmental services, because as kids leave the school system, then they need services, right? So we always have a feeder towards the services. And then for Choices for Independence, we've seen a little bit of growth over the years, and our goal is to continue to grow that program.
Thank you.
18 now?
I think I am. So we're going to talk about financing and nursing facility, but I did want to answer Representative Daniel's question from when we did the overview. You asked about nursing facility eligibility. And so typically what happens is if somebody is determined that they would like to go to a nursing home, they need to go into nursing home. They usually start with the financial eligibility first because that is the most extensive. Then once that is close to being resolved, then we do the medical assessment to make sure you're meeting that level of care. Sometimes we can do it at the same time, depends what's going on. Usually families come with a facility in mind, or then that's when they start to look for facilities to see who may have an available bed. Oftentimes a nursing facility, until someone has Medicaid, isn't going to want to accept the person because they need them to have Medicaid. So once the person has Medicaid, once the nursing facility says, yes, we have a bed, we can take this person, then we do a change of status form that then tells the department, the nursing facility submits that. So then the department knows it's okay to bill for that service.
Great. So we were asked to provide a high-level overview of the financing for the nursing facilities and Choices for Independence program. Accounting Unit 2152, this is a really important one, and part of the reason that we want to talk about this early is you're going to see this again, but it's not the most straightforward funding mechanism, and I think it's really important to understand. So Accounting Unit 2152, for this year, I think we're at about $380 million. So this is a single accounting unit, and it pays for a couple of key services. Number one is the Choices for Independence program. It's paid out of Class 506, and this is not the first time, or this is not the last time we're going to talk about this, I'm sure. And then there's also the nursing home payment line. That's Class 504. And what that represents is it represents the payments for Medicaid eligible individuals that are in nursing facilities within the state. And the slide before you shows how the funding mix works in New Hampshire. So there's a federal match. It's approximately 50%. And you'll see the blue piece of the pie there. That's the federal funds. Now, there's also a portion of that are state general funds, and then there's also county funds. And we're going to talk about this more, but we're talking about the county cap. And RSA 167-18A, within that statute, there is the county cap. And what that is, it's basically a fixed dollar amount that the legislature every 2 years determines that this is going to be the amount that the counties will contribute towards these CFI and nursing facility payments. And typically that's adjusted by HB2. I don't know if it's ever been adjusted else in any other piece of legislation, but you'll see that show up in HB2. And I'm sure once the governor's budget comes out, we'll have an opportunity to go over that section. There's also a credit in statute. The credit by default is $5 million. And in certain years, that credit has been increased, and in other years, it's been slightly lower. So I think it's been as high as $11 million, and I think maybe as low as 3. I can't recall off the top of my head. And so what you'll end up seeing in the actual accounting unit is you will not see the county cap figure in the accounting unit. What you will see is you'll see the county cap figure plus with the credit applied. So it'll be about $5 million less. There was also an element of statute that was added a few years ago that limits the growth of the county cap by 2% each year. What we found, though, in the past couple of years is we have seen expenses moving at a higher rate than just 2%. So you will see when you do, if you do look at the agency budget that was previously submitted, you will see those general funds increasing at a fairly high rate. Certainly not at a 2% rate by any means, because the cost of care in the medical field has seen some pretty high inflation over the past couple of years. So that's a very high level overview of this. I don't know how deep you want to go. I have handouts if you want to take 15 or 20 minutes, or we can pick it up another day and touch on it when we get to long-term supports and services.
Let's look at your graphic that
Sure.
you want to hand out, and then we'll just look at it real quick, and we'll get a sense of, I'll get a sense of whether or not we should go into the detail.
Sure. It's a 2-page detailed explanation.
Okay.
If we want to go through that.
Let's hand it out, give
Okay.
people a chance to read it, and then the next time you come in to talk about this subject, we should be better prepared to do a deep dive. And so I think this may come close to getting ready to conclude what we're going to do. And Commissioner Weaver, I see you back there. Do you want to say anything? I want to give you the privilege of saying something if you want about what we've talked about so far today, or whatever. Yeah, no, you can't hide. They were all pointing at you earlier. Do you want to use the microphone at the edge of the table?
Thank you for the opportunity. I don't have anything further to add right now, but thank you.
Okay, well, thank you for coming. Representative?
Yeah, one quick question, Mr. White. Yeah, thanks for the presentation. And looking at the pie charts on the county funding, is that is that the same for all counties, or is that an average, or?
Sure. So the reason that I handed out a 2-page detail explanation is because that starts to get down in the details there. What we do is we look at a 3-year history of simplistically, a 3-year history of Medicaid claims, and then there's a little bit more to it, but basically it's proportionally divvied out to the counties, and there's intergovernmental agreements between the department and each county that go through GNC that are approved, and we receive a monthly payment from the county.
So, this is my understanding, the amounts county by county would be pretty variable. This is a pretty lumpy distribution.
It's on page 2.
Yeah, it's on the second page. You'll see Hillsborough County really handles the bulk of it, and it's significantly higher than Sullivan or Grafton County or others. And again, that's based on the actual Medicaid claims over a 3-year period.
Okay, thank you. If I had looked at I would have asked the question. Thanks.
All right, do you have concluding remarks, Associate Commissioner Santinella?
No, I just want to say thank you for your time, your flexibility, and when I was able to present.
I hope
And
you're feeling better,
I feel a lot better. Thank you very much.
but I'm still glad you're beyond contagious disease level.
Yes, I am not contagious right now.
Good,
so
good.
great.
Mr. White, do you have any concluding remarks you'd like to make?
No, I think we will have going back to the conversation that we had earlier around the budget books and the presentations, we will be bringing forward a 3-ring binder. And what we'll be bringing at each presentation, we'll be bringing the presentation that has the accounting unit strings, the programmatic detail, and then we'll also have the budget briefing books, which again, if you have a chance, I encourage you to take a look at on the LBA's website. Those are really a mountain of information for each area, and they try to get at all the details that we were talking about earlier for some of these programs. So hopefully we can address that in advance. And if you do have any questions in advance, please send them along so we can prepare those before we get to the presentations, or if there's any particular topics that we haven't discussed that you kind of want to hear a little bit more about.
All right. From the committee, are there any questions for the department? In the audience, is there any member of the public that wishes to say anything? Yes, sir. Why don't you sit at the end here, and that way you can use that microphone, and we'll just need to make sure we get your name for the record. And the mic goes on by hitting the button and it goes red. There you go.
All right. Thank you very much, members of the committee. My name is Jeb Curlup. I'm with Life Coping. We're a case management agency. We cover the whole state of New Hampshire. We work on both the CFI, or Choices for Independence waiver, and also on the developmental disabilities waiver, acquired brain disorder, and in-home support waiver. So this was really a great presentation. We were particularly interested in Chris Santaniello's presentation and really appreciate all of the numbers and the hard work in this. One thing that has been discussed earlier was the rate, the lack of rates. And from a case management perspective, when we look at, for instance, the Choices for Independence waiver, and other waivers, the rates in the CFI waiver that we have, what popped out at me was that when you look at the average cost, I realize all these are different populations. They're all unique. They all have unique needs, and we have to, of course, take that into utmost consideration. We've got, with the CFI waivers, about $25,000. I think it's useful for the committee to know that these individuals have a nursing home level of care, so they are eligible to be in a nursing home at significantly greater cost. So that's about $75,000. So if you look at, they're kept in the community, or they're maintained, or they're participating in the community at $25,000 a year. So it's really, there's a $50,000 actual savings for the state and the federal government and the counties by having these individuals in the Choices for Independence waiver. The one other thing that jumped out and that was discussed and is so important is the establishment of rates. We find, or our case managers find, it's very difficult without having standardized rates in our DD waiver to basically predict anything. As the CFO for DHHS said, we have some clients in DD. We have one with Life Coping who has an almost $700,000 a year budget. So that's for 12 months. It's $670,000. And all those rates have to be just pounded out by the case managers, by the state, by sometimes the DRC will get involved. It's a very complicated process, and the benefit to all involved, the state, the federal government, of course, the participants in the program, of having these standardized rates would be hugely important, I think, in getting a handle on this. And if you look at, I just went through and did some quick math. We've got about 5,900 people in DD waiver. And if you multiply that by the number here, it's about $500 million. If you look at the CFI waiver, you've got 3,900 individuals in there at $25,000. So it's just shy of $100 million. So you're talking, and again, we have to always remember each of these populations are uniquely different. They have very different needs, but just by looking at numbers, you're seeing 5 to 1. In CFI, we're seeing $100 million for 3,900 people. Now we got about 6,000 people in DD. If we were going to compare apples to apples and have 6,000 in CFI, that's about a 50% rough math increase. So you're talking about $150 million to service 6,000 people, where we've got $500 million to now service about 6,000 people under the DD waiver. So I just wanted to mention that and thank you all for the opportunity to speak.
Don't go away, because I might, if you'll let me, I want to ask you a couple questions. But first, when we're talking about rates, I just want to I just want to know if I'm thinking about this right. The rates that we want to adjust to, I believe, are the Alvarez and Marcel 2-rate system, and we want to implement that structured system into what no.
No,
So let's save that. Okay. I just want, if I were right, I would have just kept going because, but I'm not right. So you need to educate me, and that's going to take time. I forget your name.
Jeb Kurlop. Jeb.
Okay, Jeff. So thank you for being willing to take a question. Since you're out in the community, one of the things I've wondered about, and given that I think, any fool could wander in here and realize the CFI program is a great program and we should be doing the CFI as much as we possibly can. The concern that I think we have in all of our service provision is whether or not we have the capacity. Are you able, with your workforce issues, able to scale your capacity so you can support significantly more people in a CFI environment?
Yeah, that's a great question. I think right now, and I think there's another Granite Case Management is here as well. They may want to speak to this. There's always a lack of providers. There always has been, and maybe there always will, but it used to be much better. I know in the southern part of the state, clients would have an option of 5 different agencies to choose from for their services. Now that's no longer the case. In the southern part of the state, we're scrambling to find service providers. The same way that people are, I think it's most acute in the northern, in Coos and Grafton counties, up in Berlin and the northern parts of the state. But I think, it's another thing. It's a question of supply and demand. That's why the rate setting is so important. And and it's always, at some point, the demand is going to shift and increase as the rates increased. So I would say that whole part about we're speaking about CFI. For CFI, we've got to look at the rates all the time because we're certainly not where we were pre-COVID in terms of providers. We've got less providers than we had before COVID, and things got really pretty bad during COVID, but it has improved. But I think it's a question, to answer your question, if we consistently look at the rate setting and the methodology for rate setting, we'll be able to manage that supply and demand and put more people who would like to be into CFI into CFI.
All right, thank you. Did you have a
Yeah,
comment?
I just kind of to support what Jeb shared, and thank you, Jeb, was last session when the legislature did appropriate funding for rate increases. And I don't have the data in front of me, but I do have it. We met with two CFI providers, Waypoint and Essentia, and they shared with us the impact of those rate increases. They were able to get staff who wanted to stay working there but left due to the wages come back to Essentia and Waypoint to work with individuals. They were able to add, I want to say, like 140 hours a month of services. They were able to eliminate their wait list. So the rate increase does matter, and how we went about it for the Choices for Independence waiver and for the developmental disability waiver is starting at the cost of the direct support worker. What does it cost to recruit and retain? And I do think that over time, if we are able to have stable rates, it will enhance the ability of providers to serve these vulnerable populations.
I saw a hand in the audience. You can come up, Ms. Virtue. Jeff, if you want to sit there still, you can. We got lots of mics over there. So this is Carolyn Virtue.
Thank you for the introduction, Mr. Chairman. Carolyn Virtue, Granite Case Management. I would like to reiterate that the rate increases from last year have significantly impacted our ability to fill authorized services in the care plans. The providers that Ms. Santaniello mentioned are personal care service agency providers, and that information is very good. Since I wasn't going to come up, but since now I'm up, I did have one other thing that I wanted to mention. In the system of care language that was passed last year, case management was specifically mentioned as not to be in the CFI navigator or provider groups, and that wasn't made clear today. And that is important because the CFI case management is a state plan service. So when that rate is being scored, it should be scored against like services. And to date, it has not been. That's it for me.
Well, you beat me because I have almost no idea what you're talking about. So
Well-
thank you for that. Do you have a comment on from the department?
No, I think we're okay. I think what Carolyn was just trying to show is in the developmental disability waivers, that service coordination is part of the waiver. And for Choices for Independent, it's a state plan service that serves the waiver population.
All right. Okay. Do you have any further comment?
No, I'll see you when you have your coloring book though.
Okay, good. All right. So I'm not seeing any more people in the audience wanting to say something, and I think the department's done, committee's done. So I'll end with you, Mr. Ripple, like I try to usually do. What's next on our dance card?
Well, I'm just going to work with Nathan to come up with a schedule of agency presentations starting next Tuesday, and I'll discuss that with you privately first, and then we can share it with the whole committee.
Okay, that sounds good. So thank you for coming up
Thank
with
you.
a draft on the calendar, and we just had some thoughts that Mr. Ripple will share with you on that. All right. Well, with that, I think we've covered a lot, and I'm going to adjourn today's hearing.